Hello, everyone. My name is Ken Lipson, and on behalf of FibroGen, I would like to thank the organizers for inviting us to present the Pamrevlumab program to you. I will be joined shortly by my colleague Bassem Mankabati, who will tell you about the clinical status. But before we go there, I'm going to give a quick overview of the mechanism of action of Pamrevlumab and explain what CTGF is. And then I will turn over the podium to Bassem, who will tell you about the regulatory status and the design of the clinical trials that we will be starting shortly. So let's begin with the introduction. CTGF is a member of a small family of proteins known as CCN proteins. They're characterized by having 4 domains, each of which has homology to other proteins, and a highly conserved disulfide bonding pattern shown by the black dots within each of the 4 domains. Now, CTGF is an acronym. It stands for Connective Tissue Growth Factor, but it's important to understand that it's not actually a growth factor. Rather, it's a matricellular protein or a non-structural protein that's in the extracellular matrix that regulates how cells recognize and respond to their environment. Our inhibitor of CTGF is a human monoclonal antibody that binds to the second domain of CTGF with high affinity. It has the generic name of Pamrevlumab and the laboratory name of FG3019. Now, CTGF is very much a central mediator of tissue remodeling and fibrosis. It can be induced by a variety of different pathophysiologic insults, and when it becomes overexpressed, it promotes the formation and activation of myofibroblasts, which are the cells that deposit extracellular matrix and remodel tissues. And so excessive myofibroblast activation can lead to fibrosis. Now, if the tissue remodeling occurs in the vasculature, it can create local hypertension. And this local hypertension can induce the formation of more CTGF. So there's a positive feedback loop here that leads to the progressive nature of fibrosis. There are other positive feedback loops as well with CTGF at the center. So our goal of treating with Pamrevlumab is to break these positive feedback loops, and by doing that, stop the progressive nature of fibrosis. Now, the way CTGF is thought to work is that it interacts with a variety of different molecules in a domain-specific manner. And when it interacts with these molecules, it either enhances or inhibits the pathways through which these molecules participate in signaling, and this changes how the cells respond. On this slide, we see a cartoon of normal tissue repair shown on the left as an oval. Starting at the upper left, we see that tissue injury initiates a cascade of events that starts with plugging the hole, secretion of cytokines and chemokines that recruit leukocytes to the wounded area that activate the fibroblasts and the endothelial cells, which leads to angiogenesis, deposition of extracellular matrix, and the proliferation of epithelial cells that ultimately restores the normal tissue structure and function. But off on the right, you see there's a sidetrack that occurs when the injury becomes chronic or the inflammation becomes chronic. And this leads to persistent myofibroblast activation and excessive deposition of extracellular matrix, which is also known as fibrosis. This sidetrack is where all of these positive feedback loops with CTGF occur. And so when we add Pamrevlumab, what we're trying to do is, by inhibiting CTGF, we break these positive feedback loops and we push the tissue repair process off of the sidetrack and back onto the normal tissue repair process. Now, as you all know, DMD is a genetic disease in which there's a mutation in the dystrophin gene that prevents the expression of dystrophin protein. When this occurs and the muscles are used, the muscle fibers become damaged and they're replaced, rather than with new muscle fibers, with extracellular matrix molecules like fibronectin or collagen. And you see over on the right side that as fibrosis increases, muscle strength decreases. Now, in fibrotic muscles, CTGF levels are elevated. This occurs in the muscles of dystrophic dogs, shown at the bottom left, and in the hearts of dystrophic mice, shown at the right, where the muscle expression levels of CTGF corresponds with fibrosis levels. This also occurs, of course, in people. And so our goal, our rationale for testing Pamrevlumab in DMD is that by inhibiting CTGF, we should attenuate muscle fibrosis and enable retention of muscle function. Now, we tested this hypothesis in dystrophic mice, and what we saw in mice that were treated with Pamrevlumab, that we were able to inhibit the deposition of collagen and fibronectin. This led to improved muscle strength and improved exercise capacity, as demonstrated by the fact that mice that were put on a treadmill stopped running less often if they were treated with Pamrevlumab than if they were treated with placebo IgG. And so at this point, I will turn over the podium to my colleague Bassem Mankabati, who will tell you about the regulatory and clinical program for Pamrevlumab. Thank you.
Thank you, Ken. So before I start, I want to thank the PPMD organizers and Pat Furling and her team for inviting FibroGen to present this DMD program. Before I start, I want to tell the audience here where we stand in terms of the regulatory status. In April 2019, FDA designated Pamrevlumab as an orphan drug, and in November 2019, EMA also designated Pamrevlumab as an orphan drug. In November 2019, we met with the FDA to discuss the development plan of Pamrevlumab in Duchenne muscular dystrophy indication, and we discussed the plan for the phase 3 studies across DMD indication. In early 2020, we met with the MHRA in United Kingdom to discuss the development of plan of Pamrevlumab as well. And over there, we discussed also the development plan for phase 3 studies. Overall, the outcome of these meetings was very encouraging and positive. The health authorities agreed on overall the design of the elements of the upcoming phase 3 studies, LELANTOS, which I'm going to discuss now in a second. So first trial, we are targeting a non-ambulatory patient. It will be a phase 3 randomized double-blinded Pamrevlumab or placebo in combination with systemic steroid. Objective of this trial is to evaluate the efficacy and safety of Pamrevlumab versus placebo in combination with systemic steroid in subject with non-ambulatory DMD, age 12 and older. Pamrevlumab is given 35 milligram at a dose of 35 milligram per kilogram, intravenous infusion bi-weekly. The duration of the trial is 52 weeks, and we assume the patient will receive 27 infusions over the course of the study. Systemic steroid, of course, is an oral drug. So our primary endpoint in phase 3 LELANTOS study will be a change in the total score of performance of upper limb using version 2.0 from baseline to week 52. And secondary endpoints, we divided into 3 buckets. The first bucket is pulmonary assessment. We're going to look at the percent predicted forced vital capacity change from baseline to week 52, in addition to the peak expiratory flow rate. The performance, we're going to look at assessment, we're going to look at the GRIP score from baseline to week 52, assessed by handheld myometry. And cardiac assessment, we're going to look at the change in the ventricular ejection fraction from baseline to week 52 using cardiac MRI as a more robust tool, better than the echo that's used by many clinicians. So Yes, we're going to look also at the safety assessment for this during LELANTOS. We're going to look at all treatment emergent adverse event, any lab abnormalities, of course, any discontinuation due to an adverse event. We're going to look at that. And we're going to also look at the percentage of hospitalization due to any adverse event caused by a pulmonary or cardiac cause in regards with the use of the IP, of course. Exploratory endpoint, we're going to use a Duchenne video assessment tool, which will provide the standardized way to document and assess the patient quality of movement. The caregiver will going to videotape their kids at home to measure, to see or assess the fine movement of at their home before going to the clinic. We're going to look also at the progression of the dilated cardiomyopathy in relation to the LTBP4 genotype. And we have a bunch of MRIs to assess the fibrotic changes in the muscles using the biceps brachii muscle. Cardiac fibrosis, we're going to look at by using late gadolinium enhancement, and also we're going to look at the myocardial circumferential strain as more clinical. It can give us more better understanding than ejection fraction itself. All right, so as I mentioned, LELANTOS will be a global randomized double-blinded trial. We are targeting 12 years of age and older. It's 90 patients. We are targeting 90 patients, around 45 sites across the globe. The patient will be randomized 1-to-1 ratio. Arm A, we're going to receive Pamrevlumab 35 milligram per kilogram, plus systemic deflazacort equivalent of corticosteroid. Arm B will be matching placebo plus deflazacort or equivalent systemic steroid. The screening will going to last for 4 weeks. The treatment duration is for 1 year, 52 weeks, and the safety follow-up for additional 1 month plus minus 3 days. All patients who completed the 52 weeks in this trial will going to be rolling into an OLE study where they can receive Pamrevlumab as an open label, in addition to systemic steroid, in addition to any approved therapy out there. So the patient will going to get Pamrevlumab plus any like Exonodus, Vyondys, and so forth. Phase 3 study inclusion criteria, as I mentioned, male, Brock score less than 5, equal or less than 5, of course able to perform an MRI and also to do a spirometry. We are targeting FVC between 45 to 85 inclusion, ejection fraction more than 50%, 50 and above. And if the patient was diagnosed with cardiac myopathy, we are expecting that these patients are in a stable dose of the whole 9 yards regimen of the heart failure ACE inhibitors and ARBs and so forth, beta blockers and so forth for 1 month prior to screening. On a stable dose of systemic steroid for a minimum of 6 months. And the dose we are using or we're recommending actually to be used in the trial is in compliance with the DMD care consideration working group as shown in these slides. Prednisone was 0.7 milligram, 0.75 milligram per kilogram per day, deflazacort 0.9 milligram per kilogram, or a stable dose. So exclusion criteria, it's the standard exclusion criteria we have here is an anaphylactic reaction. If the patient has a allergic or anaphylactic reaction due to any monoclonal antibodies, he should not be enrolled. If a patient exposed to an investigational drug within 30 days prior to screening, he should not be in. Of course, if the patient is taking approved therapy like Exonodus, Vyondys, they are not supposed to be in the trial within 5 half-lives of screening. Severe uncontrolled heart failure. We use the NYH A class 3 and 4 to rule them out. And also if the patient is arrhythmic, require more than 16 hours of continuous ventilation, hospitalized due to respiratory failure within 8 weeks prior to screening, he should not be enrolled. Of course, poorly controlled asthma, bronchiectasis, and emphysema should not be in that trial. And the last bullet here in that slides is that we left it to the PI judgment whether to evaluate if the patient can be enrolled in this study or not. So before I move to the study, this slides we're going to talk about the second study we are targeting, which is the ambulatory study, study LELANTOS-2, study 094. And we are planning to start this study by the end of this year. While we are in the final stage of starting or initiating the non-ambulatory study 093, which I just discussed. So in terms of the ambulatory trial, it's a phase 3 study. We are targeting 70 patients, 35 sites across the globe as well, US and Europe and Australia. Arm A will be Pamrevlumab, 35 milligram per kilogram, biweekly plus systemic deflazacort or equivalent steroids. Arm B will be matching placebo, biweekly plus systemic steroid as well. Patients who completed the trials, the 52 weeks of this study, ambulatory study, will be eligible to roll over into an open label extension where they can get Pamrevlumab as an open label, in addition to systemic steroid or any approved therapy as well. The same concept we had it in the non-ambulatory trial. All right. So per the FDA guidelines published in 2018, actually for DMD, the primary endpoint we are targeting the North Star, change in North Star ambulatory assessment from baseline to week 52. Also, other function assessment we're going to look at the 4-stair climb velocity assessment from baseline to week 52. 10-meter walk run test for a change from baseline to week 52, time to stand. Change from baseline to week 52. All right. So safety assessment, we're going to look at the treatment emergence, adverse event, serious adverse event, any lab abnormalities, any discontinuation of treatment due to an EE. We're going to have a look at that. Same exploratory endpoint. Actually, we're going to use the same Duchenne video assessment that I just discussed during the ambulatory and non-ambulatory trial. And also, we're going to use MRI for lower extremities, which is the vastus lateralis, to evaluate the muscle fibrosis score in these patients. All right. So the MRI we are using as an exploratory endpoints in both trials will be evaluated by a central reader. An independent blinded centralized imaging charter will be formed to read the MRIs for us, whether it's vastus lateralis for the ambulatory trial or the cardiac or biceps muscle fibrosis in the non-ambulatory trial. And that's based on the FDA guidance to industry in clinical trial imaging endpoint process. So the DMC also will be formed in both trials and by 2 clinicians and 1 biostats personnel. The DMC committee will be defined as a charter and will be responsible to evaluate the safety, in addition to, of course, the routine FibroGen pharmacovigilance activity that's ongoing on a daily basis. Okay, so the first 4 doses we are expecting to be given in the clinic. However, any subsequent infusion of IP can be given by home health care, and that will be evaluated on a case-by-case basis if the patient lives far away from the sites, for instance. All right, I want to conclude my presentation by saying that Pamrevlumab mechanism of action, as Ken mentioned and as demonstrated actually in the phase 2 trial that we presented in the PPMD last year, showed that it can mitigate the fibrosis regardless of the genetic mutation. So all patients, despite the genetic mutation, can be enrolled in our trials. Muscular cardiac respiratory dysfunction remains the leading cause of morbidity and mortality in this population, and demonstrate actually an unmet need to get a treatment for them. And that's exactly what we showed in our phase 2 trials, that we slowed down the disease progression in the 3 parameters: muscular muscle function, and then cardiac function, and also respiratory function. FibroGen believe this is the first antifibrotic agent has shown a potential to slow down the disease progression in DMD. And that's why we decided to start our phase 3, and we had a successful meeting with the health authorities to start immediately the 2 studies for DMD program. Study LELANTOS-1, which is a study 093 for non-ambulatory patient, and study 094 for ambulatory patient. And last slides here, this is mainly for the clinician and parents. If you think that your child, or if you are a clinician and you have a patient and you think he is eligible to be a part in our trial, this is my email and my phone numbers, and also the study email. And the study is published at clinicaltrial.gov for your awareness. Anyway, thank you, and thank you again for PPMD for inviting FibroGen.